The following podcast is part of a certified educational activity titled CASCADE, Changing the Course of Symptomatic Alzheimer's Disease Early, Moving Research to the Real World with New Biomarkers to Improve Diagnostic Precision. Access the entire activity and complete the post-test at peerview.com/XXK860. Downloadable slides and practice aids are also available.
Hello and welcome to CASCADE, Changing the Course of Symptomatic Alzheimer's Disease Early, Moving Research to the Real World with New Biomarkers to Improve Diagnostic Precision. I'm Ali Atri. I'm a cognitive neurologist. I'm the Chief Medical Officer for Banner Research in Arizona, and I am very excited to be joined by my colleague, Dr. Sharon Shah, today.
Hi, Sharon Shah here. I'm the Chief of the Memory Disorders Division at Stanford University. Welcome.
Goals for today are to enhance the understanding of the relationships between tau biomarkers and really clinical manifestations and severity of cognition, function, and behavioral decline in persons with Alzheimer's disease, and to hopefully equip you with some additional skills that you can be employed through validated and emerging tau biomarkers so that we can make a really important, timely, and accurate diagnosis that's based on neuropathological changes, and also to augment the ability to select appropriate patients that could be potential candidates for the emerging disease-modifying therapies in AD, based on criteria that are available to us now. So, as just a reminder, it's been a journey in the last 3 years where we had our first drug, aducanumab, approved based on an accelerated approval by the FDA. Because of equivocal data and some other issues, this was not really covered by CMS at the time. But since then, we've had full coverage for two drugs, lecanemab first, and now donanemab. And along with it, CMS has changed its coverage decision so that both the DMTs are covered if individuals are enrolled appropriately in a CMS-approved registry and meet criteria, but also covering the biomarkers, particularly the amyloid PET, which is really, really important. So going back to about 10 years ago now, we first started separating some of the clinical from the biological in AD, and we had the 2018 criteria known as the ATN, the amyloid tau, and sort of the N was the neurodegenerative category. It was a research criteria that really tried to state that there are some core features of AD. AD is a dual proteinopathy with amyloid and tau, but also has other processes that involve the pathobiology. And the first one that was identified in that category was neurodegeneration, but there was a hint that others were coming down the line, including, let's say, inflammation, vascular changes, that also co-pathology was very important, for example, with alpha-synuclein. And at the time, we thought about the different categories of fluid biomarkers and imaging biomarkers, and there was this framework to suggest how individuals in research settings mostly can be classified through the ATN categorization. And this also applied to preclinical stages. So the recognition that individuals can have Alzheimer's, to be in the Alzheimer's disease spectrum, but not have clinical symptoms. With that recognition, initially a symptomatic stages spectrum for AD framework was proposed, and you can see this stages 4, 5, and 6 here on the right side is really the dementia stages of Alzheimer's disease, where I think 10 years ago when individuals said when people talked about Alzheimer's disease, particularly lay or even in some clinical circles, people were really talking about dementia, a phenotype of consistent with Alzheimer's disease. But there's a recognition, obviously, this is a spectrum. Nobody wakes up one morning and says, gosh, I've got all this amyloid in my head. And today I think I've gone from, no concerns to maybe subjective cognitive decline. And then, a week later, people wake up and say, gosh, I'm in the MCI stages. Or waking up one morning saying, I now have dementia due to AD. We know that this is an insidious process and takes really a long time. And the non-symptomatic stages can be, up to maybe even 15 or 20 years or more. So it's really, really important because our first generation of drugs here, the disease-modifying amyloid plaque lowering, are aimed at stages 3 and 4, really the MCI and the mild dementia stages of confirmed AD. The other realization is that the spatiotemporal evolution characteristics of AD biomarkers, even for groups, let alone individuals, can be quite varied. While they can sort of fall in these broad classes, what we know, and they can be modified and modulated in some ways by individuals' resilience and vulnerabilities. For example, a low reserve or high reserve can change the slope or when individuals show particular symptoms. What we know is that the fluid biomarkers and analytes don't give us exactly the same information as some of our neuroimaging biomarkers, for example, amyloid PET or tau PET. And the detection threshold for different groups and even individuals can be quite variable depending on what class of biomarkers and analytes and tests are used. So this is an area that is, again, very, very much rapidly changing, and there's nuance involved. So, and we'll talk about a case that's quite nuanced later on. But as background, I want to talk a little bit about this program's focus a little bit more on tau. As I mentioned, Alzheimer's is a dual proteinopathy with amyloid and tau being necessary as core features. And what we understand is, obviously amyloid itself has many different conformations and ultimately depositing in plaques, and there's an equilibrium between the different species. But as far as tau is concerned, we understand that the tau is expressed throughout the brain, and it's a microtubule-associated protein that has been postulated to have many different functions, but directly binds to microtubules and regulates their structure and function in ways that are very, very important to axonal transport and even in potentially myelination, neurogenesis, and other important neuronal functions. So the way our understanding is regarding tau in AD is that ultimately, potentially in the presence and pushed in many ways with amyloid being present, there's an increase in phosphorylation of tau that leads to abnormal folding, self-aggregation, and spread and seeding in tau species through anatomical pathways. And these sequential steps are certainly both targets for drugs that are emerging, as you'll hear, but they also are important because of our biomarkers and what they're measuring. So again, in a simplified form, you can see and look over this slide in your own time, but there's going to be increased phosphorylation, decrease in dephosphorylation. Ultimately, this destabilizes the microtubules, and there's depolymerization, and then the phosphorylated tau actually unbinds, and then you have these species that ultimately end up in tangle formation through multiple intermediate steps. The interplay between amyloid and tau is complex and is and also leads to many other pathways that induce probably a synaptic dysfunction and neurodegeneration. So in Alzheimer's disease, in sporadic Alzheimer's disease, one of the hypotheses is decreased clearing of toxic amyloid species, particularly the oligomeric kind of A beta 42 that are more toxic. Whereas in inherited familial Alzheimer's disease, the hypothesis really is that there's much more of this toxic substrate being made. But ultimately, oligomers become fibrils, protofibrils, and fibrils. They become non-soluble and deposit in plaques. And in the presence of this toxic kindling, in many ways, once the tangles start, amyloid is almost an accelerant for the spreading of an increase of abnormal tau species and propagation. And one of the important factors is that this is bidirectional. So once you actually start having the abnormal tau hyperphosphorylation cascade, this can actually induce more A-beta oligomerization and become a positive and bad, unfortunately, feedback loop. And all of these can then lead to synaptic dysfunction, oxidative stress, calcium dysregulation, metabolic dysregulation, mitochondrial dysfunction, and other factors that can lead to neurodegeneration. It's important to appreciate that the seeding and spread of tau can be through very anatomical pathways, and Brock and Brock suggests that the first species really are in the stages 1 and 2. They actually occur in subcortical interrhinal regions, and later on, really, it's later on that you have hippocampal formation in some parts of the neocortex. Stages 3 and 4 spreading backwards. Ultimately, stages 5 and 6 are throughout the neocortex. And there is an appreciation, even though this tends to be the general spread, what we find in individuals is the patterns can be remarkably different. So it turns out that seeding and propagation and the amount of tangles really correlate with symptoms and neurodegeneration much more than for example, amyloid. Individuals who have certain syndromes probably have their tangles in hubs that are related to that clinical syndrome. So that was a very, very quick overview, and I'm going to pass it along to my colleague, Dr. Shah, for the next stage of taking you through the biomarkers into clinical practice. Very exciting.
Thanks, Dr. Autry. That was a really wonderful summary of the pathophysiology and a good reminder for all of us about how these biomarkers or the pathological mechanisms can come into play. Now we'll take it into the clinical setting and thinking about how tau biomarkers that are in development and really coming into clinical practice, what are the benefits for patients diagnostically, thinking about treatment? What are the current challenges that we need to overcome to really bring it to the clinic readily? So Dr. Autry reminded us about the criteria that had come up in 2018, and they were revised recently by Cliff Jack and others just a few months ago to remind us where we've come. So we still have the amyloid and tau and neurodegeneration, so the ATN, as he mentioned, but now we're bringing in some staging, timing, and we have evidence of other pathologies as well. So if I bring your eyes to the top of this table, we have the core 1 biomarkers that are really the first things to deposit. So if we're looking at the schematic of when those biomarkers start to develop over time, the first thing that we start to see change are these core 1 biomarkers. And really that's detected by amyloid PET, A-beta 42 in biofluids, the p-tau 217, 181, and 231. And then a little bit later, we start to get the core 2 biomarkers, and we can see that with the tau PET, p-tau 205, MTBR, which is the microtubule binding region 243, and other tau fragments. But we're still being inclusive of non-specific processes that are present in Alzheimer's disease pathophysiology, which is neuronal injury as measured by neurofilament light chain, that NFL, or we can see atrophy on the MRI, hypometabolism on the fluorodeoxyglucose PET scan, and then markers of inflammation with the glial fibrillary acidic protein. So that really just rolls off the tongue. And then finally, now we can have biomarkers of non-Alzheimer's disease copathology. Alpha-synuclein, the seed amplification assays are now coming into the clinic. And as we have before, we can see evidence of vascular disease on MRI or CT. And as a reminder, these core1 and core2 biomarkers come a little bit at different times. The core1 are the first to deposit. And that core1 is really detected by amyloid PET as of right now. And that's what in the red boxes are the FDA approved measures. And then hybrid ratios of A beta, phosphorylated tau, and total tau that you see in the red box there. The A beta 42/40 ratio, the P tau 181 over A beta 42, and then total tau over A beta 42. And then the core 2 biomarkers that we're seeing readily are more the tau PET. And what we see is that those core 2 biomarkers come later, more closely tied to the onset of neurodegeneration and clinical symptoms. We can combine the core 1 and core 2 to give us an idea about the stage of disease. That the core 1 is early, but you have evidence of core 1 and core 2 that's coming a little bit later in the staging. And here's the staging. So as we might expect, if we go on the left hand and the column down, the stage A, B, C, D is respective of more advancing disease and clinical symptoms, more decline in functional ability. And if you go across the table, then we see what comes first is maybe detected by the amyloid PET. A little bit later in time is tau deposition in the medial temporal regions, and then more advanced in time, maybe tau deposition in the neocortex in moderate level, and then more high uptake in the neocortical level. And as we might expect, then we would want to see typically that the stage matches the biomarker development. But there are some variations that you might expect. There's some patients have more progressed rapid disease, but you're not seeing as much matching of the biomarkers that can develop. Or if you go across, there may be some resilient patients that have evidence of more diffuse tau PET burden, but they're still in that mild stage of disease. But in general, we're thinking about these, both the biomarkers tending to match the stages. Now let's get through some of the different biomarkers, focus on imaging here. For tau PET, there's a main imaging to detect tau. What you see with the tau PET is that the location and the diffuse representation may tend to predict staging. So if you look on the left graph, we see that the tau burden, as denoted in green with presence in the medial temporal lobe, and then even more in the blue with tau burden in the more neocortical areas, can predict progression to mild cognitive impairment. Whereas on the right, we see that deposition in the tau burden in the neocortical regions can predict all-cause dementia. We also see that tau PET can differentiate Alzheimer's disease from other non-Alzheimer's disease neurodegenerative disorders. In the middle, we tend to see that in the mild cognitive impairment due to Alzheimer's disease and dementia due to Alzheimer's disease is reflected by the tau burden and tau presence. Whereas other diseases such as behavioral frontotemporal dementia, non-fluent variant primary progressive aphasia, I'm skipping the semantic variant for a moment, dementia with Lewy bodies, and other tauopathies such as progressive supranuclear palsy, cortical basal degeneration, we're not seeing that tau PET positivity, and that would make sense because we're not expecting that these types of tau PET tracers are positive in these conditions. You might expect that certain conditions like progressive supranuclear palsy or cortical basal degeneration that are also tauopathies would be tau PET positive, that actually aren't because the tracers aren't binding. Those ligands aren't binding. The caveat here is a semantic variant primary progressive aphasia, which is thought to be that there's off-target binding to the pathology that we expect to see in the semantic variant primary progressive aphasia patients, which are TDP43 pathology. What's also helpful about tau PET is that the presence and the location tends to match the phenotype of the patients. And what I mean by that, if we have atypical versions of Alzheimer's disease that are non-amnestic, we can see the tau PET burden tend to match the anatomical localization of where we might expect deficiencies or cognitive impairment. So if we look at the left panel in A, the posterior cortical atrophy patients that tend to have more difficulty with simultagnosia, visual processing, we see the tau PET demonstrate that there's tau burden in those posterior cortical areas. Similarly, in a patient who has logopenic variant primary progressive aphasia, we tend to think of a language version of Alzheimer's disease. We see the tau deposition in that dominant hemisphere in that parietal region, and patients who tend to have word finding problems, repetition problems. Compare that to our more classic amnestic Alzheimer's disease patients, and we see the tau deposition in that red in the medial temporal lobes and temporal lobes that's expected. And you can see some in the lower panels, some other areas that tau burden can be present. When we look at tau PET, we can see that it tends to predict amyloid positivity in clinical trials and research, yet the converse is not true, that amyloid positivity does not necessarily predict tau positivity. And that's because of what we think about the schematic of how amyloid deposits first in the brain, then tau deposits later. So by the time we see tau PET positivity, we're seeing about 93% associated with amyloid positivity, where that converse is not present. We see that amyloid, if amyloid PET is positive, we're not necessarily seeing that tau positivity yet. Now let's shift gears for a moment and think about tau CSF biomarker tests. Now we're thinking about fluids, what's available now, and how does that predict the diagnosis? Well, we have different ways to detect, and the FDA-approved in vitro diagnostic tests for Alzheimer's disease are the cerebrospinal fluid, or CSF, p-tau 181 over A-beta 42, and the total tau over A-beta 42. If you look at the left graph here, we see that the A-beta 42, the total tau, and the p-tau 181 have a lower area under the curve with amyloid PET compared to the right, where those ratio biomarkers of A-beta 42/40, total tau over A-beta 42, and the p-tau 181 over A-beta 42 have a better area under the curve and correlation with the underlying Alzheimer's disease diagnosis. CSF MTBR, so microtubule binding region tau 243, reflects aggregated tau pathology independent of amyloid pathology. So we see that the CSF MTBR 243 is a specific biomarker of insoluble tau aggregate pathology. And what you see here in the green on that rightmost bar is that MTBR is associated with that tau PET positivity, but some of the other p-tau species that you're seeing below on the left are more associated with the amyloid in the blue. So we see that this MTBR is an emerging character in CSF detecting and associated with tau. Finally, the tau plasma biomarkers are rapidly changing and coming to the clinic quite quickly. What we want to see about these blood-based biomarkers are really to be very clear about when someone's positive, we're really confident that they're positive. Or if the value is negative, we're really confident that it's not Alzheimer's disease. We understand that there may be some areas of intermediate probability that would likely then suggest that the patient would need referral to a specialist and have more confirmatory tests, such as CSF or PET scan. So we can see this sort of two cutoff ratio or two cutoff performance of these blood-based biomarkers. What we want from a blood-based biomarker test also is that they should have a high sensitivity and specificity that really match what we already have for the FDA-approved CSF tests. And that's particularly important if we're starting to use this to consider a patient for disease-modifying therapy. We really want to feel confident that that test is correct. What we're seeing from the p-tau 217 is that this one really differentiates Alzheimer's disease from non-Alzheimer's disease dementias. That the p-tau, the plasma p-tau 217 levels are increased by 300 to 700% in symptomatic Alzheimer's disease. You can see that on the left panel. You're not seeing that elevated if you go to the bottom of the left panel in some of these other conditions with synuclein like Parkinson's disease or some of the tauopathies such as PSP or corticobasal disease. And then finally, with some of the other frontotemporal lobar degeneration or vascular cognitive impairment, we're not seeing those elevations. And then if you look at the right panel here, we find that the plasma p-tau 217 in the black really have a nice area under the curve over some of these other markers, such as the CSF p-tau 217, over the CSF p-tau 181 that you see in the orange. And then what we had seen in the past couple years was the emergence of these plasma p-tau series, but what's rising to the top now is that 217 is emerging even better than some of the other species. So what you're seeing in these graphs here is that the p-tau 217 is really most correlated with amyloid PET positivity, better than the p-tau 181 and 231. So that's why you may start to see these not only in research, but in the clinical setting. And as you know, we went through all the different modalities with PET, CSF, and plasma. There are advantages and more limitations with each of these modalities. The PET scan, we find that, we can have PET, and particularly amyloid PET, has been available for a number of years. We have standardization. There are multiple FDA-approved tracers for amyloid and one for tau. For the tau PET, the spatial distribution can be seen, and Medicare now covers amyloid PET. Obviously, a limitation is of access. Not a lot of facilities and patients live close to PET facilities, and PET scans are costly, and this has radiation involvement. When we think of cerebrospinal fluid tests, they're widely available. They're reimbursed by CMS currently. We've had a long history of standardization and interpretation of these tests, and there are multiple FDA-approved tests now, and that can be done by radiology, neurology, primary care. The limitations is that the sampling and the method that the CSF test is done can be difficult or lend itself to some abnormalities in the findings. It's more invasive. It's a lumbar puncture, and there are contraindications for certain patients, particularly those who have who are on anticoagulation, and there may be some post-lumbar puncture complications. And as we might expect for plasma tests, it's readily available, less invasive, really convenient. We don't have any FDA-approved tests as of yet. They are CLIA certified. This can be done by any provider. The problem is that it's not yet approved by CMS, and depending on the assay and the test itself, the performance can vary, and the validity, we need to really test these in wide varied populations with different racial, ethnic, and comorbidities. Here's a list of all the commercially available biomarkers for Alzheimer's disease. Memorize this, just kidding. These are rapidly changing. So what's nice here is that you can review this at a later date, but these are rapidly changing in real time. So what may be available now may be changing in the future. And finally, when we think about other biomarkers that we see in Alzheimer's disease can be representative of other pathologies or non-specific. We've had MRI for a number of years, but we typically, maybe 10, 15 years ago, we might use an MRI to rule out other conditions such as tumor, strokes, et cetera. But now we can really be inclusive to consider that, hey, vascular cognitive impairment may be playing a role if we see a lot of vascular disease. And it can help really demonstrate or be supportive of underlying Alzheimer's disease pathology when we see focal atrophy that matches what you might expect, such as hippocampal atrophy or medial temporal lobe atrophy or parietal atrophy. We can also see when an MRI is performed with gradient echo or susceptibility-weighted sequences, we can see microhemorrhages that could be suggestive of cerebral amyloid angiopathy, which is a contraindication for getting some of these amyloid-targeting therapies. So it's important to consider use of the MRI in this setting. So now we'll get into a case discussion with Dr. Attree.
Great. Thank you, Dr. Shaw. That was a tour de force. So a lot to digest there, but you have the slides. So this is a involved case of Sam. Sam is 68 and seems to have a syndrome that's a non-amnestic mild dementia. And in this case, we don't know what the etiology is. We want to kind of work through this together. But he presents with about 6-7 years worth of progressive symptoms, including being more disorganized, showing poor judgment at times, being a bit more disinhibited, not really adhering to hygiene like in the past, and On testing, MMSE is 25, and the neuropsychological evaluation suggests that there is aspects of executive dysfunction and some aspects of processing speed that affects some other domains, but mostly really it appears to be more a frontal systems-based, along with major behavioral changes. The medical history involves high blood pressure and type 2 diabetes and some arthritis. The medicines are other than blood pressure meds, lisinopril and some metformin and a baby aspirin are really non-remarkable. Family history is also unclear, but his dad died early in an accident, so the mother was healthy. And the cognitive lab panel was not really revealing. Neuro exam didn't really show anything in the general exam, but the cognitive exam, as we mentioned, really suggests some issues with some aspects of interpersonal skills and executive function mostly. And the MRI shows at least a mild to moderate parietal, along with at least moderate amount of frontal and medial frontal atrophy. The hippocampi seem to be, probably on the smaller side, and he's got about probably a mild to moderate degree of small vessel white matter changes, and not known to have had a stroke, but there's a small lacunar infarct in the left putamen, but no microhemorrhages or superficial siderosis. And as you can see, the CSF was tested and shows an A beta 42 that is, falls, just above what you would expect of the normal cutoff, but sort of around there. The p-tau 181 is a little bit elevated. The total tau is at 230. So again, sitting just kind of below that, around that cutoff. But then the p-tau 181 to A beta 42 ratio is 0.032. So how do we think about this? Dr. Shah, do you want to kick it off?
Yeah, thanks for giving me a tough one here. He's a relatively young patient, and obviously what's atypical about Sam is that he has a non-amnestic syndrome. And so obviously what makes sense is to think about these biomarkers, the CSF that was done, to really think about whether Alzheimer's disease biomarkers can be predictive of an underlying Alzheimer's disease pathology, it being the most prevalent dementia. So it makes sense that doing the CSF would be the next step for the diagnosis. There are obviously borderline results here. We'd love to see things more clear cut to tell us, hey, this is actually an atypical, more behavioral or dysexecutive form of Alzheimer's disease. But there's some variations here that right at the cutoff for these individual values are letting us know that, it still could be underlying Alzheimer's disease pathology. Potentially, could we do additional tests? What may be most suggestive is that the ratio of the p-tau 181 over A beta 42 is a bit better than any of these individual values alone, and maybe most suggestive of an underlying Alzheimer's disease pathology, though we still have to think about a broad differential, whether vascular disease is at play or a behavioral variant frontotemporal dementia.
Yeah, I agree with that assessment. I think that the ratio, as you showed, is really probably the best. Sort of has the best AUC, and that A beta 42 is not a ratio; it's just A beta 42, not A beta 42 over 40. So that's also sitting there at the sort of at the margin. And he is on the younger side and atypical. So we still have a differential that certainly includes Alzheimer's disease part of it. So What do we do next? Well,
how about we do some imaging? What do you think?
I agree. And he's 68, so I think CMS would actually cover, certainly his amyloid PET. We actually do have frontal temporal dementia and a frontal syndrome, obviously, in the differential. So an FDG PET we could also get, but I think we can go over the money here. And
yeah, let's do it.
Okay, all right. So it turns out that he got his PET, and you don't find good gray-white differentiation, and this is a clearly visually positive amyloid PET. So what how do you think of this now?
Yeah, I mean, I think that's really helpful, saying that, hey, we see amyloid in its brain. We know that over the age of 65, though, the likelihood of having amyloid PET positivity increases. So I think that helps support that there's amyloid in the brain. But does that rule out, say, behavioral invariant, frontotemporal dementia, or frontotemporal lobar disease pathology? Does it give us more certainty that we've got core 1 biomarker with the amyloid PET? What about a core 2 with some more tau evidence? There's some hints of that from the CSF. What are your thoughts here?
Yeah, I mean, I think you're right. I think it is possible. I think certainly with the amyloid positivity and positivity and that profile, I'm leaning much more towards a this executive behavioral, early onset AD picture. But if we're able to get him a tau scan, I think that would be useful. And it turns out that actually in the research setting, Sam was able to get a tau PET, and along with some parietal tau, he had a fair bit of tau that was deposited in the frontal lobes and medial frontal areas. So one would say this is now a positive, T positive, yeah. So we can come back to Sam's case in a little while. All right, so we're going to move on and talk about the disease-modifying amyloid plaque lowering drugs that are available. I think one of the major milestones for us is that up to this point we've had what we call symptomatic drugs for the most part. And if in a caricature, if you think about a patient over time in standard care, decreasing their function or cognition over time. Generally, over years, they will decline in the way depicted in the bottom. And the symptomatic drugs really, again, these are definitions for medicine. These are not Alzheimer's specific definitions. Really work on, potentially stabilizing or improving symptoms. But ultimately, you can see from that blue curve for a group of patients, what will happen is that the slope of decline will parallel the slope of the non-treated or standard care patients. Patients still get benefit, and we know that symptomatic medications are important, both from delayed start and randomized withdrawal studies. So even late in the disease, they can help with cognition, function, and behavior. But really what's different about disease modification is, by definition, it's impacting one or more underlying disease processes. And so you can see in that red curve, you don't necessarily have the expectation of getting stabilization or a symptomatic bump for a group. But ultimately, as time increases, compared to the standard of care, what you would find is you should get evidence for slowing of that slope. And of course, over time, you want to add these all together. And eventually, we want to, with personalized medicine, hopefully get to the point where we can maintain function for people. And of course, we're many years away from cure, but we have a good start. So why are these drugs considered disease modifying? So think about again, these are in many ways our first generation drugs, just like MS drugs were 25 years ago. And which started with a biomarker evidence for them, and then changing, MS plaques on MRI. That was the biomarker. And then the initial benefit was slowing about 20% of functional decline. And fast forward 20 years later, and we've got 13, 14 more medicines, and many forms of MS are really now become a chronic condition, well managed. So the evidence comes in to show that it's doing something to a core pathology. And again, both lecanemab and donanemab, you had to come in and you had to have amyloid positivity confirmed. You had to be in the MCI stages or mild dementia stages. You had to have criteria for inclusion, including MRI criteria, because of risk of ARIA, the amyloid-related imaging abnormalities. But what you basically can see is that it was successful in target engagement, and there was a biological effect. So whether you look at PET scans or spinal fluid or plasma, individuals who were treated compared to the placebo group had amyloid biomarkers going in the right direction. And again, these are 18 months trials, and in the 18 months, something on the order of 75 to 80% of individuals will be considered amyloid plaque negative based on MRI readings, but not everybody. So that's important to know. So that's the first step that you need to show that something is disease modifying. The second step is to show that actually you're doing something to the slope for a group. And again, remember, these are group averages. This is not your individual patient. The mileage may very much vary. But what you understand from randomized clinical trials, they're explanatory trials. They're telling us something's happening for a group that's of benefit. What you can see is that whether you look at the CDR sum of box or ADAS-Cog, a measure of cognition, or an ADL measure on the bottom left, or again a composite combination of MMSE and CDR and ADAS-Cog, what you can see is very consistent results, which is a slowing of the slope of decline between placebo and drug-treated individuals, and that's somewhere in the order of 20 to 35% or so. So consistent results are really, really important that are convergent. What I'm not showing you is that actually both for donanemab and lecanemab, that if you looked at progression over 18 months, so the next stage of severity of dementia, so going from MCI to mild dementia, or mild dementia to moderate dementia, which is a big step as far as for your functionality. For both of these drugs, you had a benefit of about 35 to 38% if you were on drug, and that's really meaningful. So the other point that suggests that these are disease modifying is that when you look at downstream biomarkers, not just amyloid biomarkers, but other biomarkers, you're getting hints that there's actually a benefit in those biomarkers. So whether you're looking at synaptic markers, inflammatory markers, or other markers of neurodegeneration and amyloid entangles and tau, you're seeing signals of benefit. And these are things we can build on. And they're, again, very, very consistent and convergent. The other part that I won't get into detail is that, there was a tau sub-study for lecanemab. And basically when they, looked at people at the different stages, you saw benefit across all stages. But really the effect size for benefits were larger for individuals who had less tangles. And that's important because we're getting that same signal also from the donanemab trials, that it is important to have that early diagnosis. And the more actually tangles are spread, which then go along with neurodegeneration and cognitive being more advanced, probably your bang for the buck is you may get benefit as a group, but it may be less. Now, switching to looking at donanemab had a little bit of a different tact. Basically, you had to come in, again, MCI or mild dementia stages, but you actually had to have an amyloid PET and a tau PET. And individuals, so you had to be amyloid positive, but individuals who had low or no tau actually weren't included in the study. So you had to have either intermediate or high tau to come into the study. And so that was one thing that was interesting about it. The other one was that they had sort of an induction paradigm where individuals were randomized after 3 doses. They came up, were titrated to the dose or on placebo. And then at 6 months and 12 months, they did amyloid scans. And if individuals met the criteria for being amyloid negative, they were actually switched from active drug from donanemab to placebo to see if for the remainder of the study, if their trajectory would change or not. And the answer was it didn't. So again, here, donanemab shows that it's affecting amyloid biomarkers. It's significantly reducing plaques. And you can see as time goes on from 6 months to 12 months to 18 months, the percentage of individuals who are becoming considered amyloid plaque negative are increasing. Again, not 100% by the end of the study. And along with that, you get very consistent results, just like we saw with lecanemab. Remember, these are different mAbs. They work in different ways, as opposed to protofibrils for the most part with lecanemab. These are donanemab working in the parallel glutamated plaque conformation. But in this case, the iADRS is the primary endpoint, which is a combination of a cognitive and functional scale. And whether you look at that or the CDR sum of box, whether you look at the low median tau or the combined population, what you can see is the numbers are increasing, the slope is changing over that time, and again benefits somewhere in the 20 to 30 or more percent range. So very, very consistent results that we can build on. And again, suggestion that there are some effects on downstream biomarkers, not just for amyloid, and you can see this from the donanemab studies also. So that's the benefit side and the good side. But remember, these are infusions. They're costly. These were done in clinical trial paradigms, and the major side effects, other than infusion related reactions, which occur with mAbs and generally are tend to be quite mild to moderate and treatable. Sometimes we pre-treat people who've had them. Really, the major concern that we've seen over the last 20 years with these mAbs have been ARIA, the amyloid-related imaging abnormalities. And these are radiographic findings that may or may not have actually some symptom correlates. And in clinical trials, there were very, very specific surveillance MRIs. There were very core inclusion-exclusion criteria that brought people in. And you have two kinds. You have the edema effusion kind that represents sort of like inflammation, brain inflammation, and exudation of fluid from vessels that are leaky as you are trying to move the amyloid out. There's a traffic jam, and also amyloid that's already in the blood vessel walls can become inflammatory. Or you could have a little bit of leak, so you can have microhemorrhages or superficial siderosis. And really, the importance is to catch these and not continue to infuse people, because you can have something that's small can become very, very large. And in clinical trials, typically they were just found on MRIs, and 3/4 of them did not have symptoms. And when symptoms were there, they were generally quite mild or moderate and self-limited, usually within 3 or 4 months. And you had an algorithm how to deal with it, and pause it, etc. But uncommonly, actually serious and severe side effects did occur. Sometimes people were hospitalized, they had seizures, status epilepticus, and there was even rare cases of death and disability. So really for us, the gap is taking these things and translating it into clinical care. Because for health systems, et cetera, we have to prepare people for these kinds of things. And these are the major considerations as we're thinking about these. So selecting patients with amyloid plaque-lowering drugs you can look at the prescription information. For lecanemab, there's the appropriate use recommendations. I'm part of that a group that writes that. The donanemab appropriate use will be coming out. But generally, as we mentioned, you have to be in the right clinical stages, MCI or mild dementia. You have to have confirmation of amyloid positivity. You have to have a pretty good range of the MMSCs or MOCAs or things like that. And there are major contraindications. So on baseline MRI, you can't really have more than 4 microhemorrhages or have a lot of superficial siderosis, a lot of white matter changes, territorial infarcts or mini lacunar infarcts. There are restrictions, at least in the appropriate use recommendations regarding anticoagulants. There's cautions, major cautions of individuals getting clot busters and So this is, again, something that requires a major proficiency and coordination. And it also requires ApoE4 testing, because that is a correlate of risk. And the number of copies that individuals have of ApoE4, the more likely they may have ARIA. So the major risk factors that have been so far uncovered about having ARIA, even in this really restricted population, is so if you have no ApoE4, your chances of having ARIA are usually low, oftentimes in the 5 or 7 or 10% range or lower. But if you have one copy, it may be, depending on the drug, and double that or more. And if you're homozygous with lecanemab or donanemab, the risk of having ARIA may be up to 30 or 40% or more, or even higher than that. And it doesn't mean it's going to be symptomatic. It doesn't mean it's going to be severe or disabling by any means. But again, this is something that's important to discuss. Certainly, a dose and presence of underlying cerebral amyloid angiopathy, as number of microhemorrhages, superficial sclerosis, probably severity of white matter disease is also important. High blood pressure, MAPs that are high are an emerging risk factor for ARIA. And it turns out that for most of these drugs, both for lecanemab and donanemab, the majority of ARIA tends to occur usually within the first 4 to 6 months. It doesn't mean that it can't occur later, but that's when it usually happens. And there's a scheduling. The infusions are every 4 weeks for donanemab, every 2 weeks for lecanemab. Lecanemab has a fixed dose. Donanemab, steps you up after the 3rd dose. And there are, scheduled MRIs that should occur based on the prescription information. Appropriate use also suggests those, and appropriate use suggests that there may be a possibility, particularly in homozygous, to even do one later on, maybe around 12 months or so. There are many things that we don't know, including potentially stopping rules and other things like that that are being figured out. But with donanemab, one of the things that was interesting in the study was that, as I mentioned to you, individuals got switched over. So if they were amyloid negative, they were switched over, and the benefit didn't seem to wane. So that's a very, very quick tour, and I'm going to turn it over to Dr. Shah again to talk about combination therapies that are emerging.
Yeah, thank you for that wonderful summary to remind us what is available, what to be mindful of, and who's appropriate for these new therapies. We've talked a lot about tau and biomarkers. What about tau therapies? Are they ready for prime time? Can we think about combining them with these new monoclonal antibodies targeting amyloid? What we see is that they're still in the very early stages. There have been several drugs that have been looked at. This is a list of agents that are undergoing investigation. We can see that majority of them are in the phase 2, so early stages of understanding target engagement, best dose, and maybe some hints of efficacy. We see that most likely we'll get some more readouts, but there are different mechanisms. Some are antibodies, some are aggregation inhibitors, some are microtubule stabilization. So we're calling back to some of the complex diagrams that Dr. Attree went over in the beginning. Are these mechanisms that we're thinking about? We probably will be soon coming to development when we're thinking about not only prevention, but as someone moves through different stages of disease and has evidence of different biomarkers related to Alzheimer's disease, we may be implementing different potential therapies targeting what we see. So thinking more about precision medicine. So if we look at this figure developed by Jeff Cummings and others, we can see on the left, you can imagine someone who has no biomarker evidence of disease and cognitively unimpaired. Maybe there may be some prevention therapies targeting amyloid or tau. But stage 1, what we see from the Cliff Jack updated diagnosis of Alzheimer's disease, there may be biomarker evidence, but no evidence of cognitive impairment. And we may be thinking about treating those patients with amyloid-removing agents or tau agents, or if there's no evidence of tau yet, thinking about prevention of tau accumulation. As we move through the stages, we may have more biomarker evidence, maybe inclusive of tau presence, in addition to some mild cognitive impairment. And we may be thinking about targeting for those biomarkers in addition to prevention of any inflammation, any synaptic degeneration, or overall neurodegeneration. And as we go through the different stages and thinking more advanced dementia, now we may be rolling into symptomatic therapies, and in the most advanced stages, thinking about palliative care as well. Let's go back to that case, Sam, that we discussed earlier. So now, in thinking about Sam, we had some evidence, some biomarker evidence. Let's remind ourselves, he's 68. He has mild dementia due to Alzheimer's disease. We have a biological diagnosis confirmed with both amyloid PET and tau PET, with evidence of moderate level of neocortical uptake. And because of this, we're able to give him this diagnosis of an atypical Alzheimer's disease, this behavioral variant or dysexecutive variant. Reminder that he has vascular comorbidities. He's on treatments for those. The MRI showed atrophy and had one lacunar infarct. His genotype is ApoE3/4. Would he be eligible for an amyloid-targeting therapy? Dr. Attree, what do you think?
I would obviously have a patient-centered discussion with Sam and his care partner. And I think this is, along with everything else, there needs to be a sort of a informed shared decision-making process where I understand their priorities and help them through that, and giving them knowledge and appreciation about what's available, the totality of things that are available to them. Obviously, lifestyle, cholinesterase inhibitors, a lot of psychoeducation. And then walk them through sort of the risk-benefit calculus and side effects and alternatives that are as much individualized as possible for Sam, and put it in the context of what their goals are and priorities are, and how what the expectations are. These are not cures. So our first generation drugs are not cures. They're not going to magically reverse things, but they could be meaningful and in the right context. So as you mentioned, he would qualify as a behavioral dysexecutive mild dementia AD syndrome that's A positive, T positive, N positive, V positive, but it was also ApoE4 positive on the risk side. And because of that, we would discuss all those components. He's in the right stage. He has that one lacunar infarct is not going to disqualify him. He doesn't have any microhemorrhages or superficial sclerosis. That's good. Some of the things that are bumping his risk up are his ApoE4 positivity, heterozygous as opposed to homozygous. Probably the considerations, a little bit of having cerebrovascular disease to begin with, as we know. And we talked about, for example, in his case, really the importance of symptom monitoring and having this really good connection between the care partner and us regarding being adherent to the safety protocols and partnering together. If a medication changes, that's important. And someone like him, I would worry about, for example, if he goes to an ED and someone's considering ischemia, giving him a clotbuster, right? So again, having all those things in place so that we can have those informed discussions. But just because he has atypical syndrome, that would not disqualify him to having those conversations. And I think people need to have that autonomy and the justice of being presented this information.
Yeah, it's a shared decision-making based on the individual risks and benefits. So really wonderful summary of that. With that, let's conclude and remind ourselves some of the important points that we both went over today. It was a lot of information, but some things to keep in mind that with multiple approved disease-modifying therapies now available for Alzheimer's disease, it's never been more important to detect and diagnose Alzheimer's disease early in the disease course. Tau aggregation is a pathological hallmark of Alzheimer's disease that's closely linked to to the emergence of neurodegeneration and manifestation of clinical symptoms. There are different ways of detecting tau these days. Accurate biomarkers of tau pathology can improve that differential diagnosis and staging of patients with Alzheimer's disease. There are many complexities involved in selecting the right patients for treatment and delivering these amyloid-targeting therapies both safely and effectively. Safety monitoring and appropriate management is critical to successful utilization of these new therapies. Thank you so much for joining us.
Thanks, Dr. Shaw. It was a pleasure. Thanks, everybody.
Thank you.
You're welcome.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/XXK860.